Hello, everyone, and welcome. We are so excited to have trainees from all over the United States at different levels, but also registrants from all over the world. That included Ethiopia, London, Kenya, Burundi, Pakistan, and the Congo joining us tonight. So we saw the checklist effect that was inspired by surgeon and author Atul Gawande's award-winning book, The Checklist Manifesto. This film goes into hospitals across Europe, Central America, Asia, and Africa to speak to experts, doctors, and patients to understand the challenges faced by surgical teams to tackle the global health crisis in surgical safety. At the heart of this battle is the WHO's surgical safety checklist. So we're extremely lucky to have the documentaries director, Lauren Brown, with us. She is a director, filmmaker, and photographer who focuses on global health and humanitarian issues. Some of her other works include 6-Year-Old Fears, a short documentary featuring a 6-year-old Syrian girl as she becomes a big sister in a refugee camp that has the best maternal mortality rate in the world, and the documentary Shanti Kana, which follows a day in the life of a woman in one of the world's largest refugee camps. She has done an interactive film on Ebola in Liberia called Ebola Choices, and is now remotely directing a documentary on essential workers in New York City during COVID-19 titled When the Shifts Change. So I'd like to welcome her. And then additionally with us here to answer questions tonight is a general surgeon from the film, Dr. Ed Fitzgerald. He is the clinical advisor to the Lifebox Foundation and global healthcare executive to KPMG International. His experiences help him share unique perspectives with global partners, providing strategy, policy, and operational expertise in areas such as healthcare systems design, population health management, quality improvement, and innovation and implementation. So welcome to our very accomplished panelists for the night, and thank you for being with us through the screening and for this Q&A. I know that a lot of the students at our school are really excited. So I'll be taking questions from the registration form as well as the Q&A. It should be in a box below for everybody tuning in. So I'll incorporate those both together as we move through the session. So the first question for you guys is actually for Lauren. What has inspired you to become involved in global health filmmaking and documentaries? And can you talk about what inspired you to make this documentary about global surgery?
So I actually started doing documentaries while I was still working in the narrative film industry, so working on TV shows and movies and whatnot in New York. But was getting really bored with hearing actors repeat the same lines over and over again. And so I was really inspired to explore the documentary world actually by trying to make a documentary series on football or soccer. And in that, I got to go to 11 different countries in that process. That was basically like my master's degree. And afterwards really wanted to continue with it, but didn't have a plan of how to do that, and had to start working again, after I finished that filming, and found there was a hospital in Haiti that was looking for a filmmaker. And at the same time, Lifebox Foundation reached out to me to ask me if I would be interested in making a documentary on global surgery. And so, all signs pointed to be filming in healthcare, and I went with it. I mean, how could you not want to cover a topic that 9 out of 10 people in their life will encounter, and that more people die from than some of the the biggest diseases that people research and work towards? So for me, it was a no-brainer, really, and it's just kind of extended since then, because I care a lot about human rights, and I care a lot about people and healthcare and their access to it. And if anything, the documentary just solidified many of those feelings that I had had for quite some time, and have continued to focus a lot of my work on understanding more about healthcare and bringing that perspective, that non-medical perspective to it, to then try and make it accessible and understandable for people who are the decision makers or are the participants in healthcare.
Absolutely. Did you find the switch from working on topics that didn't have anything to do with healthcare to switching into healthcare and global surgery hard for you, or no, not really?
I found, there were definitely times I was extremely intimidated. I was diving into something that people dedicate their lives, a lot of years, a lot of money in schools. You know, they make sacrifices for their families in order to try and keep people healthy and alive. And I was just this outsider coming in who was trying to find a way to bridge the gap between the people, you know, the people they help and the people doing the helping. And so, yep, I mean, I could definitely tell you there was one doctor in Haiti who was not happy with me having a camera at first. But then, you know, I'm quite grateful that you know, we broke the ice eventually, and she kind of understood that I wasn't there to just try and like steal away a story and not come back. So, and she then has, I've become great friends with her, and we've developed a wonderful relationship. So it's interesting how with enough time and patience and just observing and learning and caring, you know, it can make a difference.
Absolutely. Thank you for making it a more accessible and like publicly approachable topic for people. Our next question is for both of you. Based on your experiences, what are the most important elements of global surgery that need to be developed in the coming years?
So I think it's a great question, and the problem is the temptation is to say all of it, because there is so much still to be done. And I think you have to pause and reflect a little bit about how much has been achieved in the last 5 years since the Atlantic Commission on Global Surgery, which many people take as sort of day zero for global surgery in the sort of modern era. If you want to be academic about it, it can boil down to access, need, quality. But I think wrapped around that, there's still a great need for advocacy to actually raise it as an issue, and it's something that I've been mulling over the past few weeks. I think I wonder what impact the current COVID crisis will have on strengthening health systems around. I think you know, we made huge strides in the last 5 years on addressing all of those issues and raising awareness. And I think that there is a risk now that resources are going to be and perhaps need to be diverted, but not losing the momentum on strengthening global surgical systems in the background as well.
Do you think that the impacts of COVID-19 will draw attention to the topic of global surgery as it's also expanding the capacity of critical care for patients, or do you think that it will distract away from the cause?
I think it's difficult to answer at the moment. I think there's an important factor. I'm involved in the COVID Surge collaborative group at the moment, looking at surgical outcomes globally in patients with COVID-19. And those outcomes are not good. Most hospital systems around the world have paused non-urgent, non-emergency elective surgery. That's going to have a huge impact on the need for surgery. It's also, when you actually start to look at some of the results that are outcomes for patients affected with COVID undergoing surgery, their outcomes are poor. And I think it's very likely that elective surgery is going to be paused for quite some time at the moment. So I'm certainly worried that actually coronavirus will be to the detriment of global surgery.
Yeah, makes sense. Okay, so our next question. As you have surveyed access to safe surgery across the globe, are there any LMICs that you think have made leaps in increasing access to safe surgery and follow-up of their citizens? Why do you think those countries have been successful while others have not?
I think it's hard to, I mean, so the documentary itself shows a lot of numbers and countries, but it's, you know, it's a snippet at the end of the day of the different systems and people in those systems for each country. So I think it's a bit of a challenge to judge an entire country based on definitely my exposure and experience. But there's, you know, one thing that's, I think, quite incredible is Dr. Alexi from Haiti. He's not from Haiti, he's from the US, but he's lived and worked a lot in Haiti, and he set up a patient navigator program, which is pretty cool. And so he found that one of the biggest barriers to access for people in Haiti was the people in the mountains. It can take 10 hours. So that young boy that you saw, it took his mother and him 10 hours to come down to the hospital from the mountains. Geographically, it's not a very long distance. It's just a matter of the terrain that they have to traverse in order to get there. And so that's a huge barrier. And then once they get to the hospital, they can't always read Creole. And then they have this fear that, you know, they're going to either be taken advantage of, or they're going to be misdirected, or they're not going to get the care that they need. And so a lot of times people just stay in the mountains. And so he set up this really great patient navigator program that literally just employs their community health workers, but they're even, you know, they don't dispense medications or anything. Literally what they do is they search out the need. They use cell phones to try and track and get geographical data for who needs what, and they stay in charge of the list of elective operations with the hospital. They keep in touch with them to make sure that they then can bring people down from the mountains in a safe and effective way, so they're not away from their families for longer than they need to. They can navigate the hospital process quite easily, and therefore improving their access. And it's a really cool program, and one that would be amazing to see rolled out in other places. But it takes time, it takes training, it takes funding, it takes, you know, lots of things. But that's one improvement that I've seen in that sense. You know, and then other ones, you know, in some countries, like I've seen in Ethiopia and Mongolia, they train a lot of community health workers or people who would respond to emergencies for like very limited surgical capabilities. And that's in a country like Mongolia that has a very spread out population. That's huge because, again, access is a huge issue when it comes to, you know, by the time anyone would have complications, getting them back from the steps in order to one of the regional hospitals would be quite challenging. So I think, you know, looking at, it's been interesting to see how other countries are adapting their workforce to try and meet this needs, and how, you know, especially us from the US or from any other countries, I guess, in the North or the West, if you want to look at it that way, like maybe we need to start doing that too, because we have workforce issues as well. And maybe looking at the burden of responsibility when it comes to surgical care to keep it safe, but like we can't keep it safe, and we can have, you know, programs and instigators like this to have us, you know, give us the confidence to do that. So you know, those are a couple interesting places and things that I've seen. Have you?
I think, I mean, the great thing is there are a number of countries that have made big strides, that have implemented or at least developed national plans around surgery. I think the one I'd flag from my own personal experience is probably Rwanda. It's where my journey in global surgery started back in 2013. And I think the one thing I would flag there is it's been a whole surgical system strengthening with really strong leadership and buy-in from the government and from the Ministry of Health. It's been a really interesting, almost sort of microcosm of development from specialties at a sort of vertical level, but horizontally through the mandated adoption of the surgical safety checklist and a lot of the work that Lifebox Foundation has done around that. So I think for me, that's one particular country that I would flag as having been very successful in this area.
That's very cool to hear about the development perioperatively of safety, both using the checklist intraoperatively or before and after, and then also hearing that access to safe surgical care doesn't just mean that it's there, but that the barriers to the patient getting there is also a big problem. So next is, please share something that you learned about global surgery from your experiences in those countries that you weren't able to include in the documentary.
I guess I'd say, okay, well, in a lot of hospitals, one of the major issues ends up being, I mean, you saw some of that story, and that's Kenneth and trying to explain to his mother that he has to donate blood in order to, someone has to donate blood on his behalf in order to receive the surgery. And that's usually because countries don't have a lot of these low and middle income countries don't have a regular blood supply. They don't have a blood bank that can keep them. Actually, in a country that I've been to more recently, South Sudan, that's the major reason why people end up dying, is just from not being able to have access to blood supplies. So so you see the scene where Dr. Alexi tells the mother that she has to donate blood, that, you know, to try and bring the father to, but then the father's not present anymore because he believes that his son was cursed. What you don't see, and then you see him going into the hospital and you see him having the surgery, and what you don't see is what happened with that. And now in a lot of cases, they'll find someone else or another relative, but Kenneth lived in a very, very, very remote area. There wasn't really any other family around him. The mother was really struggling to raise the children and came down alone without anyone else with the baby in order for Kenneth to have the surgery. And so I donated for Kenneth. But clearly that's not something I can really put in the documentary, but it was a no-brainer for me because I'm O positive. And so, for anyone who does end up traveling and doing any work once coronavirus allows us to again, or working in low and middle income settings, definitely donate blood. And if you can, for now, I would say too, if you're able to at a hospital, go and donate because they may need it as well with the world being a bit different now. So that's one thing that wasn't really included in it.
If I'm going to be brutal, I think one of the things that's when you're filming and you're essentially a guest, or we're doing a project and you're being hosted, you naturally don't want to embarrass the host or create a difficult situation. But I think if I'm being brutal, one of the issues that's significant, and I think we've started to tell the story of a little bit, is around corruption in healthcare, and particularly within that around medical equipment and the issues around that, be that problems of procurement, really poor, shoddy equipment. There have been a number of issues that we've seen, I think probably most recently in Ethiopia, around equipment that's been purchased that's, it's lasted 3 months and it needs to go in the bin. And, people have been missold and ripped off, and it's a real significant issue that I think there is mileage in the WHO trying to address around procurement and supply chains in healthcare, and which obviously particularly impact surgery and anesthesia.
Wow. Another topic that we've talked about in our program is donation of equipment from high-income countries to low and middle-income countries, and then not giving them a manual, or a manual that's in the wrong language, or not having the resources to maintain that equipment. Is that also something that you saw when you were filming?
Really significant, and actually that was a big focus of the work with Lifebox a number of years ago, and just last year our team had a paper published in BMJ Global Health looking at that. It's a huge issue. Guidelines are often not followed, and often these are people trying to do well. But I remember one of the things that really struck me first working at some of these hospitals and low resource centres was what people call the medical equipment graveyard. And everywhere you go, there will be a corner of the hospital or the hospital grounds with just equipment that's falling apart, that's been donated. There are no consumables. There was never an instruction book. It's broken, and it just gets pushed into a corner. And you see that time and time again, and it's a huge problem. And I think often it ends up being a burden on the receiving hospital or health system that doesn't have any means of repairing this, of getting the consumables to make it work, and it creates a real issue. Despite the fact that often mostly it's well-intentioned, with some planning and organisation around this and proper communication, two-way communication with hosts, I think we could probably do a much better job of this.
What do you think makes equipment last for shorter periods of times? You said that some equipment lasts for 3 months. Is that because it was donated, already used, or is that because of certain things that exist in the environment, like electrical surges?
It's a bit of both. It's a bit of both. So I think the big problem that we saw in Ethiopia was brand new equipment that just failed, and it was never good quality. It was never robust. It was never suitable for that environment, and I'm sure it was sold knowing that was all the case. And when it broke, it was broken. And for the particular hospital we were at, that was a huge investment in a new autoclave sterilizer, and the loss of that majorly impacted the ability to properly sterilize and circulate surgical equipment in a timely fashion. And we heard stories of impact on patient care because of that. So that's one side. I think the other side is absolutely, as you mentioned, used equipment. Perhaps it might even be at the near expiration, at the end of its usable life in the place that's donated it, or it may just be that it's actually not suited to the environment. So a big problem we've come across in places is delicate, sensitive equipment, particularly lab equipment, but also monitoring equipment as well, donated, and a hospital or a country having a poor, irregular power supply. One of the most common things you see is the electronics in those units just getting fried. If anyone who spent time working in these areas, I've certainly seen that with one laptop battery. It's an occupational hazard of working in some of these environments, and so there are ways and means around that. It can you can be designed in to the equipment, and so some equipment is just more suited, has a wider operating range for the sorts of issues you encounter in a low resource environment. And if that isn't the case, then you can get power adapters, for example, if it's a power issue, a voltage regulator to try and stop that being a problem. So it can be addressed with some thought and pre-planning.
Okay. Thank you for answering that. I'm going to read off a question that is similar to something that you had mentioned earlier from the registration form. I would like to hear about if the director experienced any resistance or hurdles when filming with regards to certain people not wanting to speak openly about their experiences with unsafe surgery. Additionally, were there ever groups that tried to stop them from speaking, such as hospital systems, government agencies, etc.? If so, how did the director overcome these barriers?
Well, I think the biggest barrier, which I completely avoid in the entire documentary, is not really diving into or touching any of the US healthcare system. I think that's the first barrier, mostly because as an American, I can say that it's a challenge to show inequity in access and have that be comparable to other countries. And so while we had the US is shown in it, it's mostly shown as, a place where people come together to try and, work through some of these problems, more so than looking at the healthcare system itself. And also, film in the US with HIPAA laws and with patients and everything. I have done other filming there, and it can be quite complicated, which is unfortunate because I think there's a lot of stories there that need to be told. And there's, I'm doing the project I'm doing now is with, I have a couple nurses and a redeployed doctor and an anesthetist who are all self-recording themselves. But, now a few years down, I know to say, please don't record yourself when you're at work unless you have full permission, and not encouraging people to do it, which is why I have people filming when their shifts are changing. So yes, it can be, I basically try and as much as I can avoid and skirt around that issue because it is inevitably a no in the US at the times to film inside of a lot of hospital situations. Other barriers I face at times where I'm just trying to think back to, sometimes it was just in Moldova, we went to a clinic and there was no oxygen, so there was no patients, so we couldn't film anything. So sometimes it's just lack of that. But for the most part, a lot of the doctors and nurses and anesthetists that I spoke with were quite passionate about this issue being understood because of the fact that, I think the thing I really tried to show the most in the film, Ed being one of the participants, is that it's not the doctors that don't want to do more, and it's not that there's all these other things that come into play, and the checklist helps to kind of break down some of those barriers in its sense. And so, it allows places that say, there's a great line that I didn't include in this documentary with a doctor from India called Navjit Roy. I did a wonderful interview with him, and I've used some of that footage in other places. But, he said when he was looking at the checklist and it said, is pulse oximeter attached? The barrier in India was like, well, we don't have a pulse oximeter. So do we just not continue the checklist? Or have we not done it right? Someone said during the screening, it's just a place to start. And I definitely think that it is. So as far as patients, I don't know if anyone noticed this either during the filming, but other than Canes, no one's names are used during the film. And that was intentional. And even in the credits, we put anonymous under their names, not because they asked for it. They gave us their names and their permission to use, but because we just felt it was, I felt it was a universal story. In other words, that, you know, patients have all different kinds of issues, but they all need to be cared for in the same way. And so to just make everyone, you know, and at the end, I think one of the first screenings I did, I was like, let me just try this and not put anyone's names in and see how I feel about it. And I felt fine about it. And no one's really said, I really wish I knew these people's names in order to know it, because you know their story just from watching and listening to them.
I also remember, and Lauren is forgetting, a particular occasion in Rwanda, filming in Kigali, when Lauren was filming one of my colleagues, and a very heavily armed Presidential Guard commando decided that we should not be filming at that location. And instead of stopping, Lauren continued filming my colleague and left me as the fall guy to try and negotiate with this commando why we should be able to continue. Bit of a hot spot.
Did you feel like there were... We're breaking up a little bit.
Go ahead.
I think we broke up a little bit at the end of that.
Oh, that's a shame. Ed was just saying, sorry, my internet, it seemed to drop a bit. Ed just said that, you know, there was a time where I was filming for another project that he was there, and we were approached by some law enforcement in Rwanda, and I just kept filming because I was almost done filming and I really wanted to finish, and left him to kind of negotiate terms and conditions with him. But then I said that, you know, he's been okay, and he's all in one piece now, so it was fine in the end. But yeah, you do get issues, but when it comes to filming and access and permissions, a lot of times I can't tell you how many hospital meeting rooms I've sat in for hours waiting for permissions for like one person to come and give me their blessing to film. But I know it's essential, I know it's necessary, and I have no problem waiting now. I was in Liberia a couple of years ago with someone who hadn't had that experience before, who's getting very frustrated about whether we were going to be given access. And I was just like, this is part of the process, you know? And if they say no in the end, there's nothing we can do. But, you know, the least we can do is wait, and then I need access there to film and permission to film. So it's a process. It's part of filmmaking.
Were there a lot of centers that said no at the end of the day?
No, well, for the checklist effect, we had permissions in advance for most of the places. So yeah, that was because we had to spend money in order for me to fly to them and to travel. So we had to at least have commitments from some places. Although I have to say, we didn't. Like our permissions didn't come in for the UK until like the day before. So that was a bit later as well. But all the other countries and the places I filmed, we had permissions in advance.
Speaking of equipment, so we have one of our attendees, Sam, asked, what equipment do you shoot with that you find to be travel friendly in low resource settings, including challenges you might face with electricity and transport?
Yeah, so when I filmed the checklist effect, I was filming with 2 Canon DSLRs. Now I shoot with 2 Sony DSLRs. They're slightly different. I now shoot 4K, so very similar, but the same concept. They're small. They don't take up a lot of space. You know, if surgery is something you're interested in, or really, I mean, it's been applicable then to, refugee camps and other places that I filmed. You don't have a lot of space, so you need to stay small. It needs to fit in your carry-on luggage, and you need to be able to take enough batteries with you to make them last, because sometimes you don't have power overnight. And so generally I've changed my package to now I have like 6 batteries for each camera, which can last 2 days if I need it to most of the time. It depends on how often I'm filming and what I'm doing. And then also the important thing is like the lenses and the camera bodies fit in this one bag that I have, which I'm happy to share if anyone's actually interested. That can go under the seat in front of me in any airplanes if I ever get to fly again. So I've basically had it all figured out, and now it's all on hold. But yeah, so just anything that you can do to just keep it small, keep it lean. I've filmed with very big cameras before. They can make some amazing images. I think, it's where you position the camera and how you frame it. You can do some great things with your phones now, which is what I'm filming or the participants in New York are filming the documentary on that I'm doing now, which I think there was another question for, if you want me to just answer that one quickly as well. Can you talk about what issues you expect on the oncoming documentary regarding COVID? So I'm focusing on essential workers. So and I'm a New Yorker, so I should preface it that way too. And I felt that for once I wanted to make a documentary about my home city, and that I wanted to cover all of the people who are still working right now, because I know it's not just medical professionals. And so there's been some interesting challenges, like things you wouldn't expect to run out in some hospitals from some of the footage I've been reviewing. If we're talking about medical things, like there's a nurse a maternity nurse, who had to make a TikTok video in order to get diapers donated because her hospital ran out of diapers. So there's things that, because we're so focused on PPE now and supporting the essential workers in that way. There's other supplies and items that are getting left behind when it comes to dealing with medical conditions. So it's challenging. So we started filming earlier in April. I'm still getting submissions in now. So it's and the emotional toll that it's taking on people so far is quite harrowing. I mean, I think the day I started asking people to film was the day that the death toll had risen past 9/11. And I think that's the last time I've seen any kind of solidarity like this in New York. So it's really interesting seeing and understanding the different perspectives that are coming in. I have a mailman, I have a subway driver, I have a doorman, this is all affecting us in different ways. And it's really, I think going to be a very interesting documentary to see how that happens. But I'm asking people to film when they're not working, specifically also for safety purposes. I always care about that because these are less than ideal times to put any kind of additional risk into anything they're doing. And so I ask people to film specifically when they're not working, and also to make sure that they can keep their conditions safe as well.
Yeah, I really look forward to that coming out. Do you guys have a date for when you think it'll premiere?
Hopefully in June, but we'll see. It's to be determined. I mean, it depends on, I guess, how and when the ending is. Will I end it before the virus outbreak, or will I wait and just to see if I want to film what it's like after things things have come back down. So one last thing is, Sam asked another question. For the audio equipment, I record all audio separately. So Rule 101 in filmmaking is if you can't hear it, you will automatically turn it off. So no matter how nice the picture is or how beautiful it is, if you can't hear it, then people just completely disengage. So I just use a separate recorder, and then you can sync both the on-camera sound and the separately recorded sound afterwards, and replace it. So you can just put a little microphone closer to the person speaking and connect that to a recorder, and then combine the two, basically.
Okay. Also from the chat, in a different chat area, Ibrahim asked, are patient fears based on certain unfortunate events or more on superstitions?
Well, go ahead.
I think depends where you are, actually. I think I remember being struck by visiting a really rural district general hospital in Ethiopia, and often these hospitals, so certainly the new ones, they're attractive. They've got beautiful gardens, and I remember remarking to the chief of medicine how beautiful the garden was, and I got a very matter-of-fact reply back, which was, well, yeah, we have to make it look nice because otherwise people just think you come and die here. And I remember being really kind of taken aback by that, actually. And so, and for many people, that isn't superstition, that's just fact. Their loved one goes to hospital and they die, and the hospital is a place of death. And so people avoid going to the hospital, even if they're ill and potentially with a treatable, resolvable condition, because a hospital is somewhere where you go to die. And that's no different to hospitals in the US or UK 100 years ago. The superstition aspect, yes, that is also the case, and I think that's much more culturally related, and so it depends on which country and where you are in the world. But that certainly has bearing on understanding the need for healthcare and access. And so there'll be many places around the world where what we would recognize as being the formal healthcare system is only accessed after the patient has already seen the local folk healer, for example. And so there are quite a lot of issues around patient education around that and correcting some of those superstitions. I'd say finally, it also has an impact on patient safety in unexpected ways. And there are certainly countries and cultures where an adverse outcome from a patient safety perspective is just seen as being God's will. And so there can be issues about helping the healthcare workforce understand what is a preventable event from a patient safety perspective, because often these are seen as or excused as being God's will rather than a preventable adverse event.
Right. Powerful. Similar to a Q&A question that came up live in the chat, we also have one that is on the same topic from the registration form, so I'm going to read that out. Now that students are recognizing the need for global surgery through platforms such as the one you've created and getting involved in programs, how do you see the landscape of global surgery changing in the upcoming decades? What challenges do you envision along the way, and what do you think is the best way for trainees to get involved?
It's a great question.
Many questions at once.
Yeah, I mean, so one of the things about global surgery is, like nothing else I've ever seen in my career, is the role that students have played in getting on board with it and driving it. It has made a huge fundamental difference, and it's something that's been noted right up to the WHO. And harnessing that enthusiasm to draw into programs and be able to meaningfully contribute is being really important, and that varies depending on the program. So a number of years ago now, when I was still working full-time with Lifebox, we started to set up the student program to help, which began as an advocacy program. And you look at the years rolling forward, what perhaps started off as being a student who was involved in local promotion of the issues at the medical school became elective placement and spend time on the ground, who's now become a trainee and is able to actually make a meaningful contribution and spend time out helping share their skills and deliver patient care. And so that graduation of interest is really starting to play out and play a big role now. What's lacking, I think, is a sort of single point of access for students to be able to get into those many programs and opportunities that are available to them. 5 years ago, when the Lancet Commission came out, there wasn't even really a way to join it all up. And now, at least, I think in the UK, there's GSSA, there's obviously the Incision and the global surgery groups. Being able to get into those and link those up with the programs that are available, be that academic departments of global surgery, be that foundations like Lifebox. I think there's a lot of different pathways to get involved. But there's also a real community that bring that together and have the interest, which is just remarkable. And I think that is going to be a generational change. You know, global surgery is not going to not be a major topic of interest, because everybody who's got on board as a student is now taking that through their careers, which is absolutely fantastic to see. And I guess my final big tip would be, there is that sense of community. There is a real camaraderie around people who are interested in and working in global surgery. And when I was first getting interested, I connected with people with similar interests. And now people do that and reach out to me, and I get messages on Twitter and LinkedIn and emails from people looking for suggestions and connections. And I think for people who are looking for opportunities, that's still one of the best ways of actually being able to connect with the family that's interested in this area.
Thank you for that. Do you think there's a role for, like while you were filming, did you bring trainees with you across seas?
Do you mean medical trainees?
Yes, or film.
Yeah. So I didn't bring any over, and I did not bring any medical trainees over. Actually, that's not true. So she's now a registered doctor, but at the time she was not. It was a good friend of mine who I lived with in Haiti. She came with me to Uganda. And that was it. At the time she was still applying to medical school, so she wasn't quite a trainee yet, but she was very interested in the topic and supporting, and she also kind of knew how I like to shoot and log my footage and help me with that. So so while she was preparing basically her medical school applications and she had already taken her tests, she came with me to Uganda. In some of the other countries, I had, like in Moldova, I had a few trainees there, local trainees. Actually, in most of the countries, in Guatemala, I had local trainees. I mean, to be honest, they were in so many places. They were essential to helping me with translations, with access, with understanding the purpose of the documentary and talking with different governing bodies. And I'll never forget in Moldova, I kind of shared a little bit about it during the screening. The anesthetist who had arranged it, along with his son, who was a trainee, they had a meeting with us with the Minister of Health, and I brought with me, so this was not a medical trainee, but like a camera trainee to Moldova, because he helped me with a lot of the visual effects and he wanted to do more camera work. And so he came with me to film. And so before we're about to go into the meeting, he goes, great, let's just like kill all the time that it takes for you to set up your cameras and do everything. Let's just do all that now while we're waiting. He has us waiting outside the conference room now. And I was like, absolutely not. And he was like, but we waste so much time setting these cameras up every single time. And we know what we're going to go do. We're going to go in there, we're going to interview them, and we're going to go out. And I was like, no, because there's like relationship building that happens in that. And plus, like, he could just decide at the last minute he doesn't want to let us put him on camera. And then we'd look like we'd look quite foolish walking in with our cameras blazing and trying to, talk to this guy. And so we walked into the conference room and we had an 1.5-hour lecture on the history of Moldova. And by the end of it, we were nodding and smiling and agreeing. And by the end of it, we had this awkward pause. And then I said, that was really, really useful. Would you be okay if I put you on camera now and asked you, just a couple of the questions that you had prepared? And there was this, again, monumental pause. And he was like, yeah, that's fine. That's fine. But, he made us work for it, in other words. And so, so helpful in getting me access in different ways and in supporting the project. And I think no example of that is better than the work that Envision did to translate this documentary into 10 different languages.
I'm seeing a great opportunity for a Lauren Anders Brown apprenticeship scheme here.
Yes. I'm sure students would be really thrilled about that. So the next question is, since the debut of the movie, have you seen or been made aware of any changes in the field of global surgery surrounding the use of these checklists, or have you seen have you seen it progress since you've left?
So impact's a hard thing, I would say, to manage with any documentary film, or at least to measure, let's say. But it is wonderful when, there was one screening that Ed brought me into. It was a very small screening at a university. And they didn't know who I was. I kind of just sat in the back of the classroom on the side and didn't say anything. And before the movie started, one surgeon from Cameroon leaned over to another surgeon and said, oh, the checklist. Yeah, we tried that. It just didn't work. Like, whatever. And I was like, okay, interesting. Not going to say anything. So we played the film. And then at the end of it, he said, well, maybe we need to look at that again. And so for me, it's kind of hearing sometimes those small moments that make people who felt like it was, the checklist was one thing to them, but then they saw it used and implied in a different way as being quite useful. And then more recently, in October, I was in Lebanon and got to film in their major government hospital. And, if someone doesn't know you, surgeons are always quite skeptical when you go into their operating theater and whatnot. But I assured them, I've done this before, and showed them the checklist effect and everything. And so I went in there, and I've been learning Arabic, and it was the first time that I was able to recognize the checklist in another language without, being prompted or them knowing how much work I had actually, or the whole team knowing how much work I'd actually done with it. And that was quite powerful, like a personal moment. But whenever people kind of look at it differently, I think that's great, because people think it's this really rigid, structured, tick box thing, when reality is, Ed, you've done a lot of work with people adjusting it to their different cultures and You know, like in Guatemala, you know, one barrier for them starting out was that the government wouldn't give them paper to do the checklist. And we've seen options where you can have the checklist on the wall when it's applied differently, and you can call it out in that way. So anywhere that I see where it's like slightly adapted and it's not just a piece of paper is always really refreshing and reassuring.
I would say as well that 10 years ago, there was a lot of debate and discussion, valid or not, but there was a lot of debate and discussion about whether the checklist really achieved anything. It was probably too easy to dismiss it. And I think one thing that's significantly changed now is that you don't get that argument anymore.
Yeah.
You know, there is a body of evidence that really demonstrates the value and benefit of using the checklist, and the conversation has moved from the benefit to actually the implementation, and the benefit is not really in question anymore. There was a 10-year essential decade after the original implementation, global study from the Global Surge Collaborative Group published before Christmas, which actually demonstrated absolutely internationally, 10,000 patients, emergency laparotomy, significant association with lower mortality and lower complication rate. And that sort of inarguable evidence has really cemented the checklist's role in perioperative practice now.
You mentioned that, for example, in one of the locations, they didn't have a pulse ox, so that couldn't be on the checklist. What other modifications did you guys see when implementing them in different countries?
I would say that's the most common, not having a pulse oximeter, or also having a pulse oximeter and it being so routine that to include it on a checklist is seen as being almost disrespectful, which is a challenge.
Or they have one and it's not functional. So that's what we saw in Guatemala. Was we saw one in the operating room, but it, like I said, when I walked in, it was just dead silent and it wasn't beeping, and they couldn't get the sound to work. So, it would require the anesthetist then, or the anesthesiologist, to watch it nonstop, but that's not the reality of a lot of low resource operating rooms. So, they can check off saying the pulse oximeter is attached, but it's not fully working.
The checklist was always, and I think this is a common misconception, the WHO checklist was always designed to be adapted locally. And actually trying to, if you visit a hospital and they have the same original WHO one that was published all that time ago, if you see that and it hasn't been adapted to the local pathways and workflows, the order in which things are done, then I usually take that as an adverse sign, because it means nobody's really actually done a proper implementation to see how's it fit in with work as it's actually done. What do we do at which stage? How do we phrase the questions that mean something to our local staff, our local culture, our local practice? So seeing an adapted checklist is a really positive sign that someone's owned it, engaged with it, and positively implemented it and thought about how it fits in a system. And I think you need to go through that process to actually to make it work, but most importantly for staff to feel like it's something that they own, that it's theirs, and that it fits with what they do.
So a great example of this actually in the film, but something we couldn't really talk about with the time that we had, was in Uganda. They at that hospital, they noticed that when they were doing the checklist, they like to just kind of skip to the part where they counted the instruments afterwards. So they would do everything really quickly, and then just really, they enjoyed, for whatever reason, they really enjoyed counting everything to say, like, basically their job was done. And so the quality of how they would actually do those first few steps wasn't as good. So they started printing the checklist on 2 sides of paper. So everyone in the room would know when you got to the point of having to count things, because you would have to turn over the paper and it would be very clear to everyone. So kind of self-monitoring everyone, and just making it a bit more of an option where behavior, kind of forcing behavior change a bit in that sense, for the betterment of the patient and the whole team.
Right. Very cool to hear about how if you modify it to your own culture, ownership creates better participation.
Yeah, there's there's a famous study, New England Journal of Medicine study from Canada, which was one of the big studies calling into question the benefit of the checklist. And one of the points that I pulled out of that at the time was they requested, I think it was looking at province-wide implementation in Ontario, where they'd mandated implementation of the checklist. And they'd contacted all of the hospital centres and asked them to send them a copy of the checklist. And something like 98% of the checklists they received from all of those hospitals in the province were the same original WHO checklist. And that to me said, well, it's no surprising you're not seeing the good outcomes from checklist use in Ontario, because you haven't implemented it properly. Nobody has adapted it. Nobody has owned it. Nobody's built it into the workflows. And so I think there's points like that that it kind of can be really easy to miss. But that was a sort of killer point in that New England paper that sort of said to me, well, this result isn't a surprise.
Yeah, that's a super interesting great point. So the next question, as a director, did you feel you had completely free reign to represent the story how you felt it should be represented? Were there any pressures to represent pieces of your story in more positive or negative lights?
I'm smiling at that question because the thought of Lauren ever accepting being pushed into a position of showing something that isn't how she wants it to be is not going to happen.
Sarah, I'm sorry, can you say the beginning of the question again? I think it dropped out a little bit.
Sorry.
That's okay. No. I think it was just the internet.
Someone did comment that I was soft, so I'll speak up.
That's okay.
As a director, did you feel you had completely free reign to represent the story how you felt it should be represented? Were there any pressures to represent pieces of your story in more positive or negative lights?
So I did have free reign to show it in the way that I wanted to, but the way that it was shot and the way I wanted to show it were in very different orders and ways. So the original concept behind the film was, creating this kind of thread, if you will, from showing the different problems and challenges and issues. It's very classic, storytelling, especially documentary. You show the problem, then you show the solution, and you show the change afterwards. And so I kind of also added a separate kind of arc and storyline visually, which was, and no one really notices it really, but I was filming it over the course of a year, and to have it feel like you were going through the seasons. So starting off in harsh, difficult summer, and then, going into autumn, which is when things start to change, winter when things are frozen and not changing and hard, spring when new life is growing and there's potential for a different kind of a future. And so when I got to Moldova, and it was a very mild March, that wasn't really in my plan, to be quite honest. And every little bit of snow or ice, I was kind of, completely filming it from every single different angle. But at the end of the day, it was a great arc to try and include with the different things I wanted to include. The last place I actually filmed in was Guatemala, which opens the film. The third place I filmed in was Uganda, which is the last place that I filmed in, or the ending really of the film. And so I had to be, it was a huge lesson in being flexible, especially towards the end, because my storylines, what I wanted to show was just so much more narrow. And the hardest part, as I said, as I commented on during the movie, was that it's really hard to show things that aren't there. It's really hard to show the missing gloves. It's really hard to show for anyone who doesn't understand medical equipment, to not hear a machine beeping that's supposed to beep. So, I got there and I got what I wanted, but it was hard and challenging to try and show it in a way that people could kind of understand. And I think, I was so grateful for the doctors there and the cleaners who let me interview them and talk about their conditions. Because we're being interviewed in a government hospital is always a bit precarious, but people were quite passionate about it. So though I think, the cesarean section in Uganda was definitely one of the scarier things to film. and to be completely powerless to do anything about it. So there was myself, my friend who I brought with me, who was, the trainee that you had asked me about and I spoke about earlier, and a UK anesthetist who had traveled with us, who had worked in the region before. And the second that the lights went out, they both wanted to just like go and do something, kind of like we can't just stand here, we have to do something. And I had to grab them both and then like go like this, because I was like, we can't do anything. And the best thing we can do right now for people to understand this is to do nothing and let it be. And thankfully, there was backup light, because at some point it was going to be a bit challenging of how we could get out of that situation. But there was backup light. They did have a system, because it happens quite regularly, for how they could check to make sure that they could continue and everything was okay. And it was quite powerful then to see that all kind of develop in action. So yeah, there are parts that I definitely had no control of, but some of those are the most amazing moments, I'd say, within the film. And the ones that I did have control of, I still love how a lot of it turned out. So the whole opening I filmed in Mexico by myself on the Day of the Dead, because I really wanted to show, again, how do you show people, consequences of this, and how do you do it metaphorically in a way that people aren't just going to shut off the movie in the first 5 minutes that you're watching it, because it's too hard or too much for them to see. So there was a lot of thought and planning that went into all of the shots that were there. I mean, we got ourselves invited to a member of parliament's wedding in Uganda to get those wedding shots. So the list goes on, but it was an incredible experience, and one that I'd love to be able to show it for other issues within global surgery and within global health.
Yeah, I said this earlier, but I think it's before people got on, when you see something as a filmmaker, you see it for everybody else. So not having them step in made that moment really impactful, even just for us watching it today, because I think all of our stomachs dropped when we saw the electricity go out. I had people texting me saying, "Oh my goodness, I can't believe that just happened." Right? Yeah. So it showed what. A
question is sometimes, did we turn off the lights? And it's like, no, absolutely not. Like, yeah. No.
So our next question from the registration form was, what are the major barriers to implementing checklists, and how can organizations, institutions, and academia contribute to aid in the widespread adoption of these practices in other areas around the globe where this culture is not present or where there's resistance to it?
I love this question. It's a great question. There is a PhD in the answer to this question. I've spent whole mornings or afternoons on master's courses and trying to unpick that. It's a big area. So I mean, this was one of the things that got me interested in the checklist, because it's the coming together of medicine and implementation science. And most, if you look at medicine, if you look at healthcare, by and large, we're pretty bad at change. There is no course at medical school to tell you how to implement change in healthcare, and yet, fundamentally, we really need to be able to do it. People talk about, in our lifetimes, our practice will change probably more and faster than at any other point in the history of medicine as new developments and innovations come along, and yet bench to bedside time, from lab to patient actual implementation of a new drug or treatment, is somewhere between 12 and 18 years. So we are not set up for change in healthcare. And part of that is the culture, because inherently we are a conservative. It's together of the art and science. But for something like the checklist, I think you really had a great example of something that is a really important, urgent change. And yet, as I said earlier, now we don't question that the checklist is beneficial. But that's 15 years since the checklist project started, and 12, 13 years now since the New England Journal of Medicine paper was published. It's taken a long time to reach that point where the benefit isn't questioned. So what can you do to change it? Well, I mean, that was a big part of my role with Lifebox Foundation, was to try and unpick that and actually look at what good looked like for implementing change in healthcare in respect to the checklist. And actually, some of the best models for that are not to be found in healthcare. You're more likely to find a successful model for change at your local business school, because of the commercial imperative that surrounds that we don't always have so much in healthcare. And it boils down to communication, to culture change, which really fundamentally you can't rush and takes time. But there are lots of models, strategies, tactics that you can put in place to try and accelerate that implementation. But when it needs something as fundamental as a behavior change, then you're probably looking at the most difficult aspect of change. And Atul has looked at this in one of his previous books and one of his fantastic articles in the New Yorker about, if you look at the advent of anesthesia, that was adopted around the world internationally in the 1800s remarkably quickly, whereas the advent of sterilization and sterile practice, it took decades, nearly a century, to be fully accepted. And there's a lot that he's looked to unpick about why some innovation in healthcare is adopted really quickly, and why some is really rejected and not. And it's a really interesting area. There's a lot of different influencing factors in that, and in that particular case, it's about who derives the benefit. If you can give a patient an anaesthetic as a surgeon and do the procedure and get a good outcome, it's easier for you, it's easier for the patient, it's adopted. Sterilization, the immediacy of the benefit wasn't seen. A septic infection caused a poor outcome at a later point down the line, and the beneficiary of that wasn't the surgeon. Nowadays, you're held accountable for surgical site infections. Back in the day, you weren't. And so really the person who stood to benefit, it was indirectly the patient, and therefore one step more difficult to try and implement sterile practice. So it's a fascinating area. And as I say, there's a PhD in answering all of that properly.
Similar to what you're talking about progressing the field of medicine, are you a member, or do you know about ERAS or ERAS, Enhanced Recovery After Surgery Society? Do you want to give your opinion about that society?
I'll give you an opinion which is much, and I say this with sort of some regret, because I have an unfinished paper that has never quite got published around ERAS. So I fundamentally believe in it. I think it's the right thing to do. But this paper was around, actually, again, who derives the benefit and who you're handing off the problems to. And so there's a lot has been written about the reduced rate of complications, of returning a patient to normality earlier. The study that I looked at many years ago, which never quite actually made it into a journal, we actually looked at patients who'd been discharged in an ERAS scheme, but followed up with their GP, their family physician. And actually, their opinion was, all ERAS is doing is moving minor complications out of the hospital into the community. It's not that these complications don't occur, and it's not that they're just not getting fed back, because a minor surgical site infection, instead of becoming a hospital problem, just becomes a family physician problem. And actually, it was really interesting, because community doctors had a really poor opinion of ERAS, because they were being left to pick up the pieces.
That's really interesting. I haven't heard that before.
No, if I'd got the paper published, they would be more widely known.
If anyone has any other questions, speak up now, because I think that we're going to bring this to a close. I'll ask one more question as we do that, but in the meantime, ask your questions now. Can you talk about surgical subspecialties that have been involved in global outreach, and whether or not there are any challenges in obtaining volunteer opportunities due to being too specialized?
This is a sort of slightly tricky area. So I mean, pretty much every specialty will have humanitarian groups working in global surgery now, which is fantastic. And to some extent, that's always been the case. Before I don't want to say fashionable, but in a way post. And this is a good thing. I don't mean this in a bad way, but post Lancet Commission on Global Surgery, the much greater awareness, the much greater interest, it has become more fashionable. And so groups that, especially groups that might not have been there previously, exist, and there's many more of them. And I haven't come across issues with that in smaller specialties. There's perhaps fewer groups, but they're still there, and perhaps finding them and connecting with them is more difficult. The wider issue here is the ongoing debate and controversy around voluntourism, around surgical groups doing good with good intentions, going to visit, but essentially not engaging in skills transfer, or indeed delivering surgery which is simply not sustainable in that host country. And I remember when we were in Rwanda a few years ago, it wasn't specifically surgical subspecialties, but I remember talking with the dean of the medical school, and him saying that actually they would never be able to teach anything and get anything done in the medical school if they accepted as many different volunteering groups that wanted to come and help them deliver global health, which he always took in the way that was pitched wasn't always right, in that they, as the receiving organisation, were often told when a group was going to come and visit, and not asked. And it had got to the point where he was now starting to refuse to accept visiting groups because of the disruption it caused locally, because there weren't good plans for continuity, for sustainability, for skills transfer. And so it's a bit of a thorny area, I would say.
Do you have any advice on how to be cognizant and respectful of those international partnerships as you start to build those, as well as how to transfer short-term medical trips into creating more longitudinally based impacts in communities that you're visiting?
It has to be a two-way process, and it has to be a long-term commitment. And that long-term commitment doesn't necessarily need to be entirely the same group that are making a commitment for 5 years or 10 years, but the organization of it has to be for the long term. It has to have local contacts. It has not just be responsive to need, but actually has to properly understand what the local need is. And that local need isn't always necessarily what people want it to be who are going to engage in that. So, I mean, and surgery is a particular case point, because have been accused of going and doing the surgery that they want to do, which doesn't match up with what the local surgery is that's needed. So getting that right, and getting it right in the long term, to build relationships, to train, and to engage in that skills transfer is absolutely key.
Wow, thank you. That was a powerful ending, I think, to our Q&A, and something that we've talked a lot about in GSSA or within our program at ACCESS here at VCU. So it's great to hear it from you guys as well. I don't think that there's any other questions, but if people on tuning in have any further questions, they can reach out to ACCESS program or maybe to you too. And thank you so much for letting us see the film tonight. Thank you so much for being here to answer questions.
Thank you for having us.
Of course.
Thank you very much.
Thank you.